So good morning, everybody. My name is Yoshi Lang. I am the project executive on Medi-Cal Connect, formerly known as the Population Health Management Service, PHM service. And we're excited to be with you today. And also a little more of my background. I'm a family physician, was a PCP in Contra Costa County for about 7 years before coming to the state. And Laura, do you want to introduce yourself as well?
Yes, absolutely. My name is Laura Miller. I'm a primary care internal medicine doc partnering with Yoshi on Medi-Cal Connect. Specifically, I am the lead on user and stakeholder engagement. So, this webinar, our engagement with you all, is the core of my work on the service, and it's a pleasure to be with you here this morning. Thank you.
All right, Vincent, let's show folks our objectives. So we want to make sure you all feel comfortable, understand the goals of Medi-Cal Connect, the functions that we're hoping to provide, the current state of where we're at with the project, next steps on engagement with you all, and then we're also going to get some real-time feedback from you, and you can ask questions. So you can put those questions in the chat at any time, and then at the end we'll grab those and try to talk through them. All right, and then our agenda. So next slide, Vincent, please. We'll cover vision, goals, objectives. We got a status update for you all. We have a demo with slide shots and synthetic data to give you just kind of a flavor of what we've been building and what DHCS users already have access to now. And then we'll do the polls and feedback. All right. So I'm going to pause on this slide before moving forward because I like to just explain Medi-Cal Connect in my own words, like when I'm talking to family or friends. What are you doing at work, Yoshi? The way I explain it is that we are gathering data from various partners across the state, for example, Department of Public Health, Department of Social Services. We're putting it all together, and then we're making it available to all those partners plus members themselves, all for the purposes of closing gaps in services and improving the lives of our members. That's how I say it. And then, right, in other words, what we're talking about is population health. So on the next slide is the more formally written vision here, which is to provide a data-driven business solution that supports whole person care by integrating information from trusted partners to support population health functions and allow for multi-party data access and sharing. So when we write it down, that's what it looks like. And I want to say that living in California, it's really easy to lose sight of how groundbreaking this is. Right, no other state has rolled out a population health platform like this with this type of analytic capability. So we're doing something really innovative, and I just want to highlight that. It's really, yeah, I said excited, but I'll say it again. We're very excited about this. So the next slide is our kind of 4 overarching goals. And I'll start on the left side. Like the body in I'll start on the left side with member experience. And with Medi-Cal Connect, we will have what's called My Medi-Cal Connect, and that'll be members' view into Medi-Cal Connect. And so some of the core functionalities that we want to deliver to members, it'll be some type of portal. It might be an app. We're going to streamline access to services. We're going to help them navigate their benefits, reduce gaps in services, and enable self-service updates, meaning they can update their contact and demographic information. And I want to use the example of WIC as we go through these 4 buckets. So Women, Infant, Children program, we know reduces rates of premature birth and low birth weight, but only about half of Californians who are eligible for WIC are enrolled in WIC. And we could make, right, a huge impact if we were to increase those numbers. So in that example, a member would see, okay, here's my benefits. I'm enrolled in Medi-Cal, I have dental, I have vision, and here's this thing called WIC, and it looks like I'm likely eligible. And here's the link where I go sign up. So closing a gap in service there. The next big bucket is whole person care. And so this is looking more from the perspective of a care manager or a plan. And the key functionalities here is that we want to be able to view members' risks and unmet needs. So that includes sharing screenings and assessments. This is also about utilizing risk stratification. And so we will have a standard risk stratification algorithm that will require the Medi-Cal plans to use across the state. So we'll be able to finally compare apples to apples in terms of risk of our members. The third big bucket is population level insights. So since we'll have all this data aggregated and integrated, we're going to be able to see where are the health trends in the state, where are the most concerning disparities across the state, where are we doing really well, and we want to highlight those places. And then finally, the fourth bucket, informed policy making, of course. So we'll be able to strengthen our oversight and monitoring of the Medi-Cal program and leverage all these analytics and insights. And again, all for the purpose of improving the lives of our members. And I forgot to continue with that WIC example, but in the whole person care bucket of goals, that would mean a care manager would see their member that they're assisting, and they would see, okay, here's what this person is currently receiving. It looks like they would qualify for WIC. Let me go sign them up. Population level insights, that would be like a plan or the state being able to see, oh, how are we doing in terms of WIC enrollment in this region or with this plan? And do we want to create policy that's going to help us address disparities in WIC enrollment, for example? I do want to note, going back to member experience for a second, we are very aware of Benefits Cal, which is a Cal SAS portal, and we know about the Medi-Cal dental portal. So we are working to begin collaboration with Benefits Cal. Okay, next slide, please. I did want to put Medi-Cal Connect in context of PHM program. So I think most of you are already familiar with our PHM program, which is outlined here, right? It's a core part of Cal AIM. We are requiring the Medi-Cal plans to develop and maintain these whole system person-centered strategies. And Medi-Cal Connect is really the technology backbone that supports and drives what's happening in PHM program. And then if you look again at the left side, the scope of PHM program is really just the Medi-Cal Managed Care Plans, the MCPs, and that launched back in January of last year. But on the right side, you'll see scope of Medi-Cal Connect goes beyond the MCPs because whatever data we have and the insights we have can be used across the Medi-Cal program, not just within PHM. And then the timeline, so we've already gone live within DHCS, our first release, and then additional components are going to be available over the next 18 months or so. All right. Next slide, please. All right, so what do we mean when we say that Medi-Cal Connect will support whole person care? And what we mean by whole person care is this combination of physical health, behavioral health, social services, all to improve members' well-being. And so this is just a visual representation of what I was describing earlier about how we are aggregating data from various services. So food, meaning WIC and CalFresh programs, corrections, data, JI, involved members. We're going to have housing data. We'll have, of course, enhanced care management data. That's one of our PHM programs, social supports, and of course, health data from our claims. And this is not a comprehensive list. So the list goes on. We have a long wish list of all the data sources that we want to pull into the service. So then we take all that, and that's how we deliver on whole person care, because we'll see what are the gaps across all these things. Like, is this person enrolled in WIC or CalFresh? And then for members, it means that we have all that information and we can show them, here's the benefits you're currently receiving. Here are potential gaps in services, like, hey, you're probably eligible for this WIC program and you're not enrolled. And then, of course, getting contact information we know is essential. Okay. Next slide, please, Vincent. All right, now we're going to give you kind of a status update along with our release roadmap. So next slide, Vincent. All right, so now we're going to see the users. That's the who and the functionality. So who's getting what when? Release 1, like I said, we already went live this past July, and we call these the DHCS power users. It's a small group of folks within DHCS, and they've now gotten the fundamental requirement of Medi-Cal Connect, which is to support analytic capabilities for DHCS. So, and Laura's going to show you some screenshots of what these initial dashboards look like. We have quality measures, condition prevalence, and health equity dashboards. Coming early next year, we'll have release 2, and the idea there is to go live with all of our DHCS users. We're going to evolve the release 1 R1 capabilities that we already have, and then we're going to introduce some additional dashboards, which will try to get at program performance, for example, like trying to look at ECM utilization as an example there. Then release 3, slated for Q3 of next year, that's when the plans, county behavioral health, state partners, and agencies will get access. And we're planning for 2 ways that these users can interact with the data. So either they're going to have very similar dashboards to what we're rolling out internally now, or they can grab the data from an API. And then this will also be the time when we start collecting and sharing screening and assessment data. So those are the required screenings that are required DHCS screenings. Those are what we would be aiming to share, as well as member contact and demographic information. And then this is also when the risk stratification, segmentation, and tiering RSST algorithm would go live. And I just want to pause on RSST for a second, because that could be a whole nother discussion, a whole nother talk. But the things to emphasize about RSST, I already mentioned, plans will be required to use it. It will be fully transparent. It will take into account underutilization, which is actually very novel. The existing commercial risk algorithms out there generally do not take into account underutilization. So it's a big deal that we're going to have our own algorithm. Okay, next slide, please. Getting to release 4 in the Q3 next year. So that's a lot of you all on the webinar today. So essentially the same functionality that we just talked about going live for the plans in R3, you would get in R4. So this is our local county partners, service providers, healthcare delivery partners, tribal partners. And then last but certainly not least in release 5 are members. And we made a very intentional decision to go live with members last, because we knew that we would only have one shot to get it right with members if we're delivering a portal, an app, etc. So we're going to deliver the capabilities that I already mentioned in that first bucket of our goals. And then we'll continue to evolve everything that we're going live with in the first 4 releases. And then after that, the service Medi-Cal Connect continues to evolve. So we'll plan to have quarterly releases for maintenance, for enhancements. And like I said, the data wish list is very long. And so we plan to continue adding more and more data and capability there. Okay, enough for me. Laura, I'll hand it off to you.
Awesome. Thank you, Yoshi. So as your user and stakeholder engagement guru, I want to dive in a little deeper into what we have done and what we plan to do in terms of engaging you all. So you can see here our segments. We've had conversations with state partners and agencies, healthcare delivery partners, tribes and tribal partners, as well as members. Those are really all of the stakeholders that are not health or medical or behavioral health plans. And we have various different ways of engaging. So webinars like today, and we do have our polling functions. So we really appreciate your engagement there. It's a great way to have your input come into what we're building. We've also had and will continue to have small group discussions. Um, so if you are interested, please let us know. We'd certainly be glad to hear from you. We've done lobby tours with members, and those were trips to Medi-Cal enrollment offices across the state, 8 different counties, where we spoke with Medi-Cal enrollment counselors and staff, as well as going into the lobbies and talking to members who were there accessing benefits, and those were incredibly beneficial. We also plan to hold focus groups, and we've done a number of surveys as well, including surveying enrollment navigators, understanding that those are the folks that are very close to the member experience when it comes to navigating Medi-Cal. So these are the engagement activities that we are embarking on. Next slide. So this is a little bit more detail on our lobby tours, the things that we learned. Um, Members really want guidance on the next step after eligibility. We realized that, it's one thing to get Medi-Cal, but then you need to get a plan and you need to get a primary care provider and you need to figure out what specialists are in that network. And that's a real area where we feel that Medi-Cal Connect can be of great benefit for members. We're thinking about having YouTube videos there, step by step instructions really on how to navigate the system. Members really want ease in navigating the Medi-Cal system and benefits. When I did one interview in a lobby with a member, she said, "I just want reassurance. I just want to know that I'm going to get what I need." We're incorporating that into our thinking here about what we're building for members. In addition, we hear across the board that updated contact and demographic information is incredibly important. If a care manager wants to reach out and the phone number doesn't work, that's pretty much a hard stop. So we want to build in that ability to update contact and demographic information. I alluded to this before, but members really want support in finding a provider or services. One thing we think about when we think about the member portal is, now you have Medi-Cal. Here are other things that are part of your Medi-Cal benefit, like dental, transportation, and then also you qualify for Medi-Cal. Here are other things that you may very well qualify for, like CalFresh, et cetera, and really making those benefits transparent and easily accessible. We learned that members are very worried about data security. With all of the scams and issues that happen with identity theft, members really care about that. And obviously, we will build that in. So in summary, we really learned a lot from members, and we're going to keep on with this kind of discovery. Um, Baljeet, I see your question about the counties. I'm going to let staff throw those in because I will miss some, but I know that I went to Contra Costa, Solano, San Bernardino, and LA. I did not go to YOLO. I did go to San Luis Obispo. So I won't bore you with the litany, but staff can throw those in. Thank you so much. Let's go to the next slide. This Yoshi did a nice layout of the roadmap of releases. This is really a roadmap of our engagement linked to the releases. So we are right here with the green arrow in Q3 of 24 doing webinar number 2. We did do our first webinar back in May and are still in the process of producing frequently asked questions that flowed from that webinar, excuse me. So that will be coming out. Some stakeholder groups may have additional touch points, and dates for webinars are subject to change, but we'll send out invites 30 days in advance. And for this engagement, we'll focus, like we've done today, on feedback, status updates, some light touch on configuration, and really identifying distinct needs of all of our stakeholders. Next slide. So I'm going to talk you through some screenshots from Medi-Cal Connect. These are screenshots of synthetic data. We can't show live data. This does not include PHI. So please don't scrutinize this for public health conclusions. But we wanted to give you a flavor of what will be in Medi-Cal Connect when it is released to you. This is the DHCS view, the dashboards that are available now within DHCS, but many of you may get similar views. And again, we wanted to provide transparency into what DHCS is currently looking at as we begin the process of integrating these new dashboards into our business processes. Next slide. So as Yoshi mentioned, we have 3 dashboards available in Release 1 within DHCS. Quality measures, which I'll talk about first, condition prevalence, and then the health equity dashboard. So this is a screenshot from the quality measures dashboard. Again, my apologies for teeny tiny font. We were not able to do a live demo. But you can see here in this top screenshot that one can select the measurement year. This is selected for 2023, and then also select the initiative. So this screenshot was selected for the CMS core set, Children's Preventive Health. So you see within that multiple clinical measures that are a part of the CMS core set. So for instance, say you are an advocacy group and interested in well child visits within the Medi-Cal population. You could select a year, as here, measurement year, and then look at the children's health preventive performance, and you can drill down to specific measures. So, the 4th one there, children's immunizations, DTaP, tetanus, diphtheria and pertussis vaccination, and look at performance across the state. You can slice and dice by plan county, by region, and also by race and ethnicity. In addition, you can see in this lower screenshot, you can get a whole state view of performance on these measures. This screenshot is for well child visits for adolescents and children. This particular example does not show a much difference in performance, but you can see on the bottom there is a legend such that it's like a heat map. Low performance would be light color, high performance would be the more intense colors, and it grades up. So again, you can get this whole state view. Next slide. We're going to look now at condition prevalence. This is where we can look at distinct disease states. This example here that we pulled, you can see it on the right-hand side in orange, is diabetes type 2, low severity. So you can see how this plays out in your region or in your county. Again, you can see the filters across the top. So we have, as I noted, the year. You can filter by Medi-Cal plan, by plan county, by region, by condition category, and this is filtered by diabetes. You can look at age, sex, race, ethnicity, and language. The other interesting thing about this view is that it pulls in utilization data, looking at for this particular group, diabetes low severity, looking at emergency room visits per 1,000 as compared with average for the whole population. So makes sense to me as a clinician. Folks with diabetes are more likely to be going to the emergency room, et cetera. Although I
And
said
Laura,
we weren't supposed to draw conclusions. Yes.
that's not a real conclusion. That is a
No, yeah.
example hypothetical conclusion. And then I wasn't sure if you pointed out that this is also filtered by race. So you can see race is in the little yellow rectangle
Great.
there, Black and African American, Black or African American.
With diabetes showing the utilization. Yes. Thank you, Yoshi. Um, So that is condition prevalence. Your eyes may be drawn to this 65.3% no condition. That's really a factor of this being synthetic data. When the dashboards are live and in your hands, it will not be that high. And then the conditions flow from the chronic illness and disability payment system, and that leverages the first and second diagnoses on claims. So that's how the conditions are lumped. Let's go to the next slide. This is the third dashboard that we have, which is the health equity dashboard. So to walk you through this, the navy bars represent the top 5 and the bottom 5 subpopulations with the biggest absolute difference in performance when compared with total population. So here we're looking at measurement year 23. The key health equity area is coned in on quality measures, and we are looking at basic population health management, preventive services. So again, synthetic data, but looking at this, we can see that we need to focus, let's say, on the bottom 5. These are areas of a screening measure and people of a certain race or ethnicity, how that group is performing on a screening measure when compared with that vertical line, which is total population average. This is really what we are discussing within DHCS is how to get curious about this data. You can look at this data, see trends, and then dive in deeper. Look at it by region, look at it over time. The dashboards are really set up for a fair amount of curious inquiry. Next slide. I think at this point I get to pass it back to my colleague Yoshi.
Sure. All right. We are going to do some polls. Yes, we can send out the presentation. Vincent, let's show the first poll question. All right, so once you have your hands on Medi-Cal Connect, we're curious about what services, programs, enrollment or utilization information would be most useful to you. And we didn't quite have enough space to make a comprehensive list, and that would probably be overwhelming anyway. So we have a partial list here. So for example, would you be most interested in enrollment and utilization of ECM? And so the list goes on here, various programs, and then we get down to sort of broader categories. G, for example, is waiver programs. H, for example, county behavioral health history, dental plan enrollment, MCP assignment, and care manager contact information. So that one's not actually a program, but a piece of information. I think the things that we haven't included, some big categories would be housing data and corrections data. So you could put that in as other if you'd like. So go ahead and scan the QR code there, punch in all that apply, the things that you're most interested in, because this kind of gives us a sense of, hey, our stakeholders, our partners out there, what are you all most interested in? And that helps kind of guide our communication and our efforts internally. And then we're going to get live results, right, Vincent?
Yes.
And Diana, a little bit more nuanced answer to your question about getting a list of the measures. It may vary. We haven't, actually, I personally haven't thought this through, but it may vary on what organization you're with if you would have access to all 150 measures. We have to think about that. But we can certainly send you the list, and we can probably show you the various groupings like bold goals, MCAS, HEDIS. Okay. Are we still getting more? Slowing down? Vincent, it looks like it's difficult to see all the bars at the same time. There's a way to do it, that'd be great. If not, don't worry about it. Maybe a limitation of the interface here. Okay, I think we're more or less complete. So that's great. So ECM is at the top. If you scroll down, Vincent, let's see if we can figure out what number 2 is. I think, yeah, community supports, maybe MCP assignment. Community supports 13%. Looked like MCP assignment was maybe, I think I saw 9%. CalFresh is up there.
I saw waiver programs like PACE looking like 9 and CalFresh 10. Yeah.
Mm-hmm. Oh yeah,
Definitely
MCP
up there.
assignment, pretty high.
Yeah.
And then Vincent, how can we see the other category, what people wrote in?
Some folks are flowing it into chat.
Oh,
So Shannon has said housing and other safety net programs like CalWorks.
uh-huh. Yeah,
Oops.
CalWorks is on our list, our data wish list.
Yeah.
Thanks, Sam. Yes,
Please,
we meant
yeah.
please write it in the chat. I didn't say that.
And please do throw other things in the chat. We are gathering long and deep wish lists.
All right. And if anyone wants to ask a question about this list, feel free to jump in. I think everyone has the ability to unmute, raise a hand. I can't remember the abilities that everybody has.
So
We just
Aleda
uh-huh.
flowed in about if a person is enrolled in ECM and with whom, super important. That's definitely within our sites. Thinking about that, getting care manager program and care manager name.
Name
And then
and contact information of
and
the care
contact
manager.
info. Right. And
Where?
then Diana Boyer, child abuse prevention programs. That's a great one.
Yeah,
That's
I
a
actually
great one.
don't know if that's on our data wish list. Diana, can you
I don't think it
tell
is.
us what is the actual data set and where it lives? Can you tell us more about that one?
Oh, well, yeah, that could be interesting. I think that would be a future thing, probably.
Sure.
In the child welfare side, we're going to be implementing a federal program where in order to claim federal dollars, we have to automate. And that's in 2026, maybe sooner. through Child Welfare System CARES. The data system is on the DSS side. And that's one method. There may be some others, and that might be worth a conversation with the Department of Social Services. There also might be something related to CYBHI in the school. Schools are receiving funding for early intervention services as well. More related to mental health, but could be child abuse related as well. So a couple ideas there.
Yeah, thank you. I'm looking at our wish list, trying to figure out if CARES is in there. I'm not seeing it in my prelim Control F search.
Well, the good news is you already have a data sharing agreement between the two state
Yes.
agencies. Yeah.
We have many data sharing agreements. Implementing the sharing of the data is very difficult. That's been one of our major challenges on the project. So, community-based adult services. Okay, CBAS. Thanks, Michelle.
It's a great one.
Where does that data live?
That is a good question to which I don't know the answer, but we can find out.
Yeah, Michelle, do you
If
know
there,
who owns that data? Okay, CDA. Yes, IHSS is on our list. ECM providers need to screen candidates for enrollment in other waiver programs. It would be helpful to verify screen in this portal rather than just relying on members' recollection. Yes,
super great.
that's great, John. We will strive to be able to do that. I think it's not going to be fully baked in when we go live with release 3, but I really like that idea. Okay, Anastasia is saying we already have CBAS data. I think, Anastasia, is that what you're saying? Oh, it is a Medi-Cal service. Thank you. Got it.
This is great.
You might guess that all DHCS staff don't know everything that's happening across the department. You would be correct. We try. Okay, let's go to the next question. How are you hoping to leverage the insights that Medi-Cal Connect can provide? So a couple answer choices here, select all that apply. Filling in data gaps, understanding population trends, using the insights for performance improvement and monitoring purposes, or to help members navigate or coordinate their care. And then, of course, you can put in others into the chat. So let us know what things would you be most interested in using. Aleda, good question. This is on our FAQs that will be published soon. Currently, in the initial releases, we are not planning to integrate into EHRs. And I meant to say that Medi-Cal Connect is not intended to be a tool for real-time decision making for members, for patients. So that's the quick answer. The longer answer is eventually. We over time we want to get as close to real time as possible. And it's also not, how should I say this? It's within the realm of possibility that someday there would be connections between Medi-Cal Connect and EHRs, but not in the near future. John, there is a chart available that details programs that have potential conflict with ECM enrollment. Ah, yes.
Well known to me. So that's a really great call out to be complete in those exclusions. It's great. Thank you, John.
I'm looking at a latest note about the community health record in Alameda County. Wow.
Yeah.
Yeah, that reminds me, wherever possible, we are striving for standard data formats. And Allie,
Yeah.
hey
And
Allie.
I was going to say to Aleda, like
Mhm.
you and I lived the community health record in Alameda County and fully recognize that with it, it needs to be the PHM service, Medi-Cal Connect needs to be very good such that people will log in. We know that stand alongside systems are not optimal, but this is, again, as Yoshi has noted, this is, planned for iteration.
Yeah, and maybe another thing to say, as former PCPs ourselves, when Laura and I first learned about Medi-Cal Connect PHM service, we said, physicians are not going to log into this thing. That is not what we should be aiming for. And so our thinking in terms of folks who are embedded in the clinical world, that maybe this would be a panel manager who would want to utilize this, but yeah, it is not a frontline provider tool. Okay. I was looking at, oh yeah, Ali's question about data lag. So great question. Claims tend to come in within a couple months. So that's basically the lag, and it's variable. Eventually, we're hoping to do monthly rolling updates to the data in the dashboard. So you'd be able to see a month over month run chart of whatever measure you're looking at. Very different and much more real time compared to what the department has now, which is annual ECRO data, External Quality Review Organization. Did I get that? So the department gets that once a year in July. So, the data in there is up to 18 months old. And so now the department and our partners will have data that's a few months old from our claims. Diana, assist with service planning to fill gaps in services. That will depend on how far counties can drill down to their county. Yes, that is true. How do I answer that? I guess I answer that by saying yes. We know, we are thinking about that one, and we'll have to figure out how we allow our partners, including counties, to drill down as much as possible to say, like, okay, we're going to look at this region and figure out who are the people that need X service, like at an individual member level. We would love to be able to do that. There's also all the PHI concerns and how do we control for that. So that is definitely something we need to solve or get it to a place that it's as useful as possible for you. Yes, later. And Allie, another question. Will the data set integrate with CARES? Yes. We are pulling in immunization data from CDPH. It's in flight right now. All right. Let's look at our poll results. How are you hoping to leverage the insights that might, oh yeah. I don't need to read that again. Fill in data gaps, great. Yeah, I think all of these are, pretty close. Great. Sounds like folks are interested in all of these. maybe a little less on population trends. Did anyone put some others? I didn't see any. If you can think of other things that you're saying, oh, I would love to leverage XYZ. That's okay if not. And feel free to come off mute. We'd love to hear your voices. Ah, yes.
Yes, thank you, Diana, about filling in,
Right.
assist with service planning to fill gaps. That's really important. Makes
Yeah,
very
that's
good
what I was,
sense.
yeah. And that's what I was talking about. For example, we would love to be able for county partners to look at, hey, who, trying to think through an example. Like we know we have low CalFresh enrollment, and then we would look in a specific region. Can we figure out who are these individuals and reach out to those individuals who would probably benefit from CalFresh who don't have it? So that's the kind of thing we would really like to do. All right. Any other questions, comments? That's all the content we had for you today. That's the update we wanted to provide and the questions we wanted to ask you all. Vincent, and I think the last slide is just questions, comments. Yeah. Oh, we do have a one pager that we published, and I think Sam or another team member was going to drop the link in the chat. What is the soonest that public can access this data again? I'm glad you used the word public because this is not public. Medi-Cal Connect will not be available to everyone. It will be available to people who work within our partner organizations because it will have PHI. So R2 for DHCS, that's first quarter next year. For plans, county behavioral health state partners and agencies, that's second quarter next year. And then for our partners, you all, so that's provider organizations, service providers, tribal partners, that's third quarter of 2025. So that's the real answer. Oh, and Laura beat me to it. I was giving a long-winded answer to your question, Dan.
And I was being quite terse. But that's okay. Amanda, I see your question. What type of feedback are we hearing in the first phase of rollout? It's a very small group of people who are using it. Feedback is generally positive, and changing business practices within a large organization is a challenging feat. So we've engaged with doing some organizational change management, really diving in to understand the work processes of folks here at DHCS and how they can use the service. So at this point, the feedback has been positive, but it also, I wouldn't say that it has changed people's daily work yet. And I think when we roll out to that second group, the broader group of DHCS, there will be a more focused change management piece there to really understand and get people using it.
Yeah, great question, Amanda. We are grappling, working on that one as well. We have a vendor, Unleashing Leaders, who's helping us basically do a very thorough organizational change management initiative within the department.
And Allie, you have your hand up.
Yeah, and sorry, I joined a little bit late because I was in transit and wanted to really focus. I did have a question about how how providers will be able to access the information for their patients. And I imagine that there's some sort of connection between the patient's assignment status to that provider, and that providers will be able to see their assigned patients from managed care plans. I wonder, what about those patients that come to FQHCs, for example, who aren't assigned? And we know that that amount can vary quite substantially. And, the patient could be consider an FQHC that they're unassigned to their medical home. So yeah, acknowledging that we have issues with assignment and that needs to be right-sized, obviously, but how does that factor into what the providers can see on behalf of their patients assigned and unassigned? Does that question make sense?
It does. It's thorny. But I totally understand the problem that you're talking about, in that, members can be assigned, but that does not mean that they know that they're there. And providers can have people assigned to them that they have never met or seen. I think the first issue to work with as we build is PCP assignment, which is easier said than done. As you know, it's really that PCP assignment issue at the state level based on the data that we have. So that's problem number one, is making sure that we are reflecting the PCP assignment as it appears in the data that we have, right? And then being able to we talk a lot about role-based permissioning in terms of people coming into the system being able to have the right to see member level data only if they are related to that member in a certain way. So that's a related problem that's absolutely in our sights, and we're working on that as well. I think there was probably one other layer in your question, Allie, but it may be something that we could do a one-off, a conversation with you, because I think you have your finger on something really important that I have also obviously grappled with over time.
Yeah, I'd really appreciate and welcome that conversation. As we're moving into the alternative payment methodology implementation, we can see that assignment does not track with utilization, and it's going to be a big lift to right size that. And I'd hate to see adoption of this really awesome platform be hindered in any way because because of that issue. And so I think there's probably some maybe technical specifications that we might be able to think through. And so, yeah, we can reach out and start that conversation with you, Yoshi, and you, Laura, for sure.
That's really
we
good.
Actually have, yeah, let's do that. And we have a work group within the project that is focused on essentially provider member assignment and trying to figure out that data piece. I saw a hand. Where did it go?
Aaron. Can you come off mute, Aaron? You're welcome to.
And then we should wrap after Aaron. Maybe Aaron's microphone is not working.
Or maybe Aaron was clapping. No, technical issues. We are sorry, Aaron. If you can toss it in the chat, maybe we can try to get to it, but we do want to be respectful of time. I want to call out that Sam Ross put the link to the Medi-Cal Connect one-pager in the chat, sort of at the 10:18 mark of the morning. That's a really great, we worked on that a fair amount. So it's a really good statement of where we are or where we were a couple of months ago. It's a great defining document, and it's short. So please do take a look at that.
Is the IPA model being considered in the PCP assignment and security design?
It is. We are actually talking with several IPAs. IPAs will fall into release 4, but yes, we're having conversations with some IPAs, and we certainly, will welcome any thoughts that you have. But yes, IPAs are in our sights.
All right, 10:26. We should let y'all go have some passing time. Thanks so much for joining. We got almost 50 people. So appreciate your input and enthusiasm, and we will be in touch.
Great.
Thanks, everyone.
Thank you very, very much.